I begin my talk.
Yes, please.
Today I'll be talking on vascular calcification and CKD. I hope my slide is visible.
Yes, Jaison. Yeah, we can see it.
I'll start. Yes, sir. Thank you. So I'll start with a case. Meet Mr. Sharma, a 58-year-old man on hemodialysis for 3 years, now presenting with chest pain and dyspnea on exertion. These are his vitals. He has a BP of 160/90, heart rate of 100 per minute, oxygen saturation of 92%. So he was found to have severe LVH, and you can see calcific aortic stenosis here, left ventricular hypertrophy. The CT coronary artery calcium score was found to be 1200 Agatston units, which is very high. So here we see a high BP, coronary artery calcification, and valvular calcification, which are often seen in CKD. With this case in mind, let's understand vascular calcification in CKD further. Vascular calcification is strongly associated with cardiovascular mortality in patients on dialysis. It's a complex process expressing similarity to bone metabolism in onset and progression. The degree of calcification in arteries is correlated with increased risk of cardiovascular events and death. We have known for many years that calcification starts very early in CKD. The data from various studies like Russo et al. And RIN study shows that the prevalence is about 40% in early CKD, that is stage 3 to 4. And by the time these patients begin dialysis, the prevalence increases to 57%. And for those on dialysis for some time, we are looking at a prevalence of 83%. Now let's look at different types of calcification. Anatomically and mechanistically, ectopic calcification is quite diverse. So within the vasculature, there is intimal calcification that occurs in the intimal layer of blood vessels and is associated with atherosclerotic plaques. It is seen in both CKD and non-CKD patients, but it's amplified in patients with CKD. I won't go much detailed into the pathogens of intimal calcification, but to make it simple, it is just atherosclerosis, which begins with LDL deposition and oxidation in the endothelium, triggering inflammatory cascade, plaque formation, and thrombosis. And then there is medial calcification that occurs around the smooth muscle-rich medial layer of blood vessels. It occurs predominantly in CKD. If you remember our case, calcification also occurs in heart valves. Valvular remodeling is driven by mechanical stress, pro-inflammatory cytokines, and molecular signaling, which damages the endothelium, triggering endothelial to mesenchymal transition, promoting calcification and mineralization. Calcification can also occur in skin, which is very rare, but a painful condition called calciphylaxis, leading to intimal proliferation, endovascular fibrosis, intravascular thrombosis, and subsequent tissue necrosis. Calcification in the medial layer of artery is a hallmark of CKD MPD, which is due to calcium phosphate deposition. This circumferential deposition of calcium and phosphate crystals in this medial layer comes with hemodynamic consequences, like that of giving the vessel a lead pipe-like consistency with increased arterial stiffening, decreased elasticity, increase in artery load resulting in LVH and heart failure. In peripheral vessels, there is increased risk of limb ischemia, and it can also lead to amputation. Mechanism of vascular calcification. Let's try to understand the mechanism in more detail. So under adverse stimuli, including calcium phosphate dysregulation, inflammation, reactive oxygen species, DNA damage, cytokines, and endoplasmic reticulum related stress, advanced glycosylation end products, all these cause the vascular smooth muscles in the arterial wall to transdifferentiate. So these vascular smooth muscles transdifferentiate into osteochondroblast-like phenotype. This happens in the presence of increased levels of osteogenic transcription factors like RUNX2, MSX2, SOX9, and Ostrix. This process is aggravated by the loss of calcification inhibition factors like MGP, which is matrix GLA protein, pyrophosphate, pegylated A, and so on. And these transdifferentiated vascular smooth muscle cells acquire osteochondroblast markers like type 1 collagen, osteocalcin, and ALP, and they lose their contractile markers. Now, in CKD, we find serum phosphate rises very late, as shown by this blue line, which you can see here. But elevations of PTH and FGF23 happens very early. You can depicted by this red and green line. This means that there is some phosphate dysregulation already in play, although phosphate rise is not seen until late CKD. It has been demonstrated that microcalcification begins in vessels in early CKD despite normal serum phosphate. This is further proven in a study published in the Journal of European Society of Cardiology in 2023, where they fed radio-labeled phosphate to CKD model of mice. And these traces were later identified in calcified blood vessels of mice, despite blood levels of phosphate remaining normal. Now, metabolic phosphate dysregulation is central to vascular calcification. Hyperphosphatemia increases the activity of sodium-dependent phosphate cotransporters like PIT1 and PIT2 in the vascular smooth muscle cells, promoting phosphate uptake and upregulating genes associated with extracellular vesicle formation and matrix mineralization. Phosphate and calcium together result in deposition of hydroxyapatite in blood vessels, resulting in calcification. So these extracellular vesicles are lipid bilayer spheres released from vascular smooth muscle cells. The release of these vesicles is enhanced by high concentration of calcium and phosphate. So these microvesicles and exons, which are extracellular vesicles, bind to extracellular matrix, and these vesicles act as nucleation site for calcium and phosphate, which aggregate and nucleate. And they form hydroxyapatite crystals. Now, this increases the pressure inside these extracellular vesicles, causing them to burst, thus allowing homologous nucleation to take place, leading to large lesions which we observe. Clinically, these lesions after homologous nucleation is termed as macrocalcification, and the earlier lesions are called microcalcification. Finally, these form hydroxyapatite crystals. Now, what are the risk factors of vascular calcification? It has been observed in various studies that increasing age and increasing time on dialysis are associated with increased prevalence and severity of vascular calcifications. Also, factors like calcium and calcium-based phosphate binders, hyperphosphatemia, vitamin K antagonists like warfarin, excess vitamin D, and even deficiency of vitamin D has been found to be a risk factor for calcification. Also hypoparathyroidism, dynamic bone disease, hypomagnesemia, and diabetes are also attributed as risk factors for vascular calcification. Detection of vascular calcification. So vascular calcification is most often incidentally detected on imaging obtained for other purposes like plain X-ray, CT coronary artery scoring. It is an indicator of cardiac risk. Echo also helps in assessing valvular calcifications. On your right, you can see images of CT coronary artery calcium scoring using Agatston scores. So a score of 0 is means no calcium is detected. Up to 100 is mild increased risk of heart disease. 101 to 299 shows moderately increased risk of heart disease. 300 and above suggests severe risk of heart diseases. Now, patients with chronic kidney disease experience accelerated cardiovascular calcifications on various sites that are presented in different temporal patterns with diverse clinical consequences. Smaller microcalcifications in the tunica intima may increase plaque instability, promote local stress, especially in valve leaflets, and trigger inflammation in vascular beds. Microcalcifications aggregate to form larger calcifications, which on the contrary stabilizes plaque and reduces plaque rupture, but can cause arterial stiffness and valvular stenosis. Here we are looking at data from Gerard London's group published in NDT in 2003, which looked at mortality associated with medial and intimal calcification. We can see that the all-cause survival and cardiovascular survival drop with calcification, whether it is medial calcification or intimal calcification. Annual increase in coronary artery calcification score more than 20 is associated with reduced survival. This data was published in the Journal of Coronary Artery Disease in 2023. So what about the treatment? So no specific therapy exists to prevent progression or to facilitate regression of vascular calcification in patients with CKD. Also, no evidence to date exists to suggest regression of vascular calcification, if at all possible, leads to improved outcomes. However, there are certain steps which we can take to prevent or delay calcification, like controlling hyperphosphatemia and optimizing CKD MPD therapies, intensification of dialysis. For calcific access, we can do wound care. Antibiotics may be administered if the wound looks infected, debridement if necessary for necrotic lesions, replace warfarin with low molecular weight heparin or direct oral anticoagulants, stop vitamin D analogs, sodium thiosulfate may be used, vitamin K supplementation may help to some extent, hyperbaric oxygen therapy may be tried. Now, what are the evidences and trials we have? So let's look at the research and evidences available on vascular calcification. This is a meta-analysis published in The Lancet in 2013 by Sophie Jamal and team to understand the effect of calcium-based versus non-calcium-based binders on mortality in CKD patients. Over 4,600 patients were included in this study. It was found that there was a 22% reduction in all-cause mortality in patients receiving non-calcium-based binders. Coronary artery calcification was more pronounced in patients on calcium-based binders in a few studies included in this meta-analysis, but this was not consistent across all studies. Next is the IMPROVE CKD trial published in Jaison. This was a randomized placebo-controlled trial in patients with CKD 3B and 4 to look at the effect of lanthanum carbonate. Patients were randomized to lanthanum 500 mg twice a day against a matched placebo. The primary outcome was change in coronary artery calcification score. So at 96 weeks, there was no difference in aortic calcification, and lanthanum carbonate also did not affect arterial stiffness compared to placebo. So despite superior phosphate reduction seen in the trial, lanthanum carbonate did not improve surrogate markers of cardiovascular disease in non-dialysis CKD patients. The IMPROVE CKD trial found lanthanum carbonate does not reduce the risk of cardiovascular disease in patients with CKD. The other trial is the landmark trial. This trial looked at the effect of treating hyperphosphatemia with lanthanum versus calcium carbonate in patients undergoing hemodialysis. This study included over 2,000 patients from various centers in Japan with at least one risk factor for vascular calcification. Patients were randomized to lanthanum or calcium carbonate. The primary endpoint was not achieved in this study. The study showed there was no significant difference between lanthanum and calcium carbonate in reducing the risk of composite cardiovascular endpoints and all-cause mortality. Also, the lanthanum carbonate group had a higher risk of cardiovascular death on post-hoc analysis. Even for all other clinical outcomes, the point estimate was worse for lanthanum compared to calcium carbonate, but the findings were not statistically significant. This is another study called the ADVANCE trial. So it was published in 2011. It's a prospective randomized controlled clinical trial to assess whether cynic acid combined with low-dose vitamin D can slow the progression of vascular and cardiac valve calcification compared to flexible dose of vitamin D in hemodialysis patients with secondary hypoparathyroidism. And it was found that cynic acid with low-dose vitamin D did produce a modest improvement in vascular and valvular calcification. This was a positive trial. Now, vitamin K trials. So I mentioned that vitamin K therapy also to some extent might help in vascular calcification. Now let's look at evidences in relation to this. So we know that matrix-Cla protein is one of the inhibitors of valvular calcification. So vitamin K is an important factor for carboxylation of matrix-Cla protein, without which this protein will be unable to act, and when this protein is uncarboxylated, it promotes vascular calcification rather than inhibiting it. So in this slide, we are looking at two trials on the role of vitamin K1 in preventing progression of arterial calcification. One is the IPAC-HD and other is VITA-VAS-K. Both compared vitamin K1 against placebo. The primary endpoints in both these trials are progression of coronary artery calcification, and in VITA-VAS, in addition, they also looked at thoracic aorta calcification. So coronary artery calcification was found to be increased in both the groups in the IPAC-HT trial, and there was no difference. And then in VITAVASC trial, there was less coronary artery calcification progression and less thoracic aorta calcification progression, but the values were not statistically significant. Also, this trial was stopped early due to slow recruitment. Now, what about vitamin K2? So we spoke about vitamin K1. Now, looking at vitamin K2, we can see there are a number of studies which were done. I will not go into the details, but you can see here that the number of patients in this trial range from 48 to 178 with placebo controls or standard of care. And if you look on the right-hand side, the trial, the results are pretty much the same, and there is no difference in coronary artery calcification with vitamin K2 in people on dialysis. So there was no positive results from any of these trials. But although VITAVASC showed some reduction in coronary artery calcification, thoracic aorta calcification, the values were not significant, like I mentioned. Now, what about those patients with CKD 3 to 5 who are not on dialysis? Again, there is no difference in coronary artery calcification or pulse wave velocity values. So pulse wave velocity values will signify arterial stiffness. So if we try to summarize the data for vitamin K, the data looks disappointing. So, although vitamin K certainly appears to be safe, the uncarboxylated NGP levels certainly decreased, which would be a good thing, but that did not attenuate calcification progression. The results were consistent for all groups of CKD, including kidney transplant recipients. And for children, we do not have sufficient data. Then there were trials conducted to see if magnesium would somehow prevent vascular calcification, because we know that hypomagnesemia is one of the risk factors for vascular calcification. So there are several trials looking into increasing dialysate magnesium, and they appeared promising and showed regression of carotid intimal medial thickness and stabilization of vascular calcification using high dialysate magnesium. This is another trial called the Magical CKD trial. This was a randomized RCT designed to test if oral magnesium supplementation could slow the progression of coronary artery calcification in pre-dialysis CKD stages. And this looked at and these patients were given oral magnesium, and then coronary artery calcification score was taken at 12 months. This is a negative study with no change in vascular calcification. Also, magnesium was not very well tolerated by patients. They had lots of GI side effects like diarrhea. Now, another study is DIAL-MAX study. It's a large study currently ongoing in Canada. It's a pragmatic cluster randomized controlled trial. Patients are randomized to receive various concentrations of magnesium in dialysis for 4 years. More than 25,000 patients are involved. Primary endpoint is all-cause mortality. And this trial is scheduled to end by spring of 2026. And then data might come in probably by 27 or so. And sodium thiosulfate. Sodium thiosulfate has been around for some time and has been used with some success, especially in calciphylaxis. So this is a meta-analysis published in NDT in 2023, looking at IV sodium thiosulfate treatment for vascular calcification. It showed that sodium thiosulfate significantly reduced coronary and iliac artery calcification and also improved arterial stiffness. But tolerability appears to be an issue. Common side effects include nausea and increased anion gap acidosis. There is no significant impact on bone mineral density. This another newer molecule called SNF472. This is an investigational drug that blocks new hydroxyapatite crystal formation and prevents propagation and formation of further hydroxyapatite crystals without interfering directly with calcium and phosphate blood levels. This was studied in a phase 2 trial called the Calypso trial. This was a multi-centric, double-blind, placebo-controlled trial, and the primary endpoint was coronary artery calcification. There were 274 patients in this trial, randomized to a higher dose of 600 mg. Another arm had a lower dose of 300 mg, and these were compared against placebo. The primary endpoint was a change in coronary artery calcification volume. And then there were some secondary endpoints also, like change in Agatston score, change in thoracic aorta calcification scores, and there is also some safety endpoints like cardiovascular composite endpoints, all-cause mortality, and it also looked at adverse events. So there was a 1-month safety follow-up also at the end of the study. Patients received the drug on dialysis via an infusion 3 times a week. And the results were found to be impressive. There was a good reduction in coronary artery calcification volume score with SNF 472 compared to placebo. And this attenuation of coronary artery calcification score was also found in aorta as well as the aortic valve. The drug was also well tolerated, and currently phase 3 trial is ongoing. This is called the Calcifix trial, and the trial is completed and the data is yet to be published. To conclude, there is no specific therapy to prevent progression or to facilitate regression of vascular calcification in patients with CKD. It remains uncertain if modifying the natural history of vascular calcification translates into improved patient outcomes. Treatment of persistent hyperphosphatemia, treatment of secondary hyperparathyroidism, regulating oral calcium intake, treatment of hypomagnesemia, and appropriate use of anticoagulation when indicated, and addressing cardiovascular risk factors are the current viable options. With that, I conclude my talk. Thank you.